Hello, this is your weekly pelvic and perineal health watch for May 16th, 2026, presented by Erwan Leroux-Meur, physiotherapist in Paris. This is an educational update, not individualized medical advice. This week, the watch retrieved 50 articles. The curation file is complete with 32 retained articles and 18 excluded items. For this episode, I chose an editorial line focused on pelvic pain, nerves, diagnosis, and functional trajectories. And the goal is not to list every article, but to follow a clinical thread: how to better recognize pelvic pain, how to avoid reducing it to a single local explanation, and how to connect diagnosis, surgery, rehabilitation, sexuality, and quality of life. The episode is organized in three parts. First, the must-read papers with strong syntheses on sexuality, exercise, pelvic floor rehabilitation, prostatectomy, pregnancy, postpartum care, and gynecologic cancer survivorship. Then a thematic dossier on pelvic pain with endometriosis, central sensitization, pelvic neuropathic pain, the pudendal nerve, pelvic congestion syndrome, dysmenorrhea, and vulvar pain. Finally, a few brief items on anorectal surgery, post-void residual urine, and sexuality in neurological disease. Must read: pelvic function, sexuality, and functional recovery. We start with a paper that goes well beyond gynecology alone. In the Journal of Sexual Medicine, Ruiz-pérez et al. Publish systematic review and meta-analysis on the beneficial effect of exercise on sexual dysfunction in women. This systematic review and meta-analysis evaluates the effects of physical activity and exercise on female sexual dysfunction. The authors remind us that sexual dysfunction may affect more than 43% of women worldwide, with a multifactorial etiology and persistent underdiagnosis and undertreatment. The review includes 23 studies, 15 of which are pooled in the meta-analysis using the Female Sexual Function Index, or FSFI. The interventions are broad: pelvic floor training, aerobic exercise, resistance training, combined programs, yoga, aquatic exercise, and core training. The main result is favorable. The FSFI score improves by a mean difference of 5.31 points compared with controls, with improvements across desire, arousal, lubrication, orgasm, satisfaction, and dyspareunia. The clinical message is useful because it shifts the focus. This is not only about strengthening the pelvic floor, it is about integrating sexual function into a broader body-based approach. For gynecologists, midwives, physiotherapists, primary care physicians, and sexologists, this meta-analysis gives a practical argument. Exercise is not just a vague lifestyle recommendation, it may be a meaningful intervention for women's sexual health. Caution is still required because heterogeneity is high and the overall certainty of evidence is limited by the diversity of protocols. But in real clinical life, that diversity may also be useful. A woman with dyspareunia, pelvic pain, or reduced desire will not necessarily need the same program as another patient. The key is to offer an active, adapted, progressive, and measurable entry point. The second must-read also comes from the Journal of Sexual Medicine, this time in men. De Oliveira et al. Publish Efficacy of Pelvic Floor Muscle Training in the Management of Premature Ejaculation, a systematic review and meta-analysis of randomized controlled trials. The question is practical. Does pelvic floor muscle training have a real role in premature ejaculation? The authors include 5 studies with 236 men and compare pelvic floor muscle training or sphincter control training with pharmacological control interventions such as dapaoxetine or with combined programs. The result is nuanced, which is exactly why the paper is worth discussing. Isolated pelvic floor muscle training does not appear to be the dominant solution. Dapaoxetine or combined approaches associating pelvic floor training with an auxiliary masturbation device or diaphragmatic breathing appear superior for improving intravaginal ejaculatory latency time. For clinical practice, this article helps avoid 2 extremes. The first would be to present pelvic floor rehabilitation as a magic answer for every male sexual dysfunction. The second would be to exclude rehabilitation entirely from the field of premature ejaculation. The more reasonable message is that pelvic floor work may have a place, but probably within a combined framework involving sexual education, breathing, arousal control, sometimes medication, and careful patient selection. For physiotherapists and physicians, this is a useful reminder. Before prescribing pelvic floor contractions to a man with premature ejaculation, we need to know what we are trying to change, how we will measure it, and within which therapeutic strategy. We then move to robot-assisted radical prostatectomy with a paper in Journal of Robotic Surgery. Suartz Suartz et al. Published NeuroSAFE-guided robot-assisted radical prostatectomy versus standard RARP, systematic review and meta-analysis of comparative studies. NeuroSAFE is an intraoperative frozen section technique designed to help the surgeon preserve neurovascular bundles when oncologically appropriate. The meta-analysis includes 13 studies, including 2 randomized trials for a total of 22,183 patients. The results are clinically important. NeuroSAFE is associated with improved postoperative erectile function with an odds ratio of 2.00, improved urinary continence recovery with an odds ratio of 1.36, and fewer positive surgical margins with an odds ratio of 0.73. Biochemical recurrence does not appear increased, and this matters for pelvic rehabilitation because continence and sexual function after prostatectomy do not depend only on the quality of postoperative rehabilitation. They are also shaped in the operating room by surgical precision, nerve preservation strategy, and the dialogue between surgeon, patient, and rehabilitation team. For the patient, the optimal pathway is not simply surgery, then rehab. It is a chain: preoperative information, technical choices, prehabilitation where possible, nerve-sparing surgery when indicated, and structured functional follow-up. For physiotherapists, this paper is also an invitation to speak the language of urologists: margins, recurrence, neurovascular bundles, continence, erectile function, and quality of life. Rehabilitation does not replace surgery, but it belongs within a functional pathway. In International Urogynecology Journal, Jin and Lee publish Effects of Pelvic Floor Muscle Training in Pregnant and Postpartum Women, a systematic review. This systematic review includes 26 trials assessing pelvic floor muscle training during pregnancy and postpartum with or without feedback. The strongest result concerns pelvic floor muscle strength. Pelvic floor muscle training significantly improves strength with an overall standardized mean difference of 1.39. The effect is present during pregnancy but greater postpartum, with a standardized mean difference of 1.74 postpartum versus 1.10 during pregnancy. Results for urinary symptom severity, quality of life, sexual function, and prolapse severity are less consistent. Interventions incorporating feedback tend to show more reliable benefits than programs without feedback. And this paper does not say that every pregnant or postpartum woman should receive the same program. It says that training works better when it is structured, supervised, and adjusted. For midwives, physiotherapists, gynecologists, and primary care physicians, the practical message is clear. The generic instruction, do pelvic floor exercises, is probably not enough. Feedback, whether manual, verbal, instrumental, or ultrasound-based, has clinical value because it turns an abstract instruction into motor learning. This matches everyday clinical experience. Some women think they are contracting but actually bear down. Others recruit the gluteals, adductors, or abdominal wall. Others can contract but cannot relax. Useful pelvic floor training is not a sheet of exercises. It is a learning process. Still in obstetrics, Huberlant et al. Published in Journal of Gynecology, Obstetrics, and Human Reproduction Feasibility of transperineal ultrasound in the delivery room for the management of obstetric anal sphincter injuries, a randomized controlled trial. The trial investigates immediate postpartum transperineal ultrasound performed in the delivery room by a non-expert obstetrician in primiparous women after vaginal birth with at least a second-degree tear or episiotomy. Women are randomized to clinical examination alone versus clinical examination plus transperineal ultrasound. The goal is highly practical: to improve the detection of obstetric anal sphincter injuries and assess the impact on anal incontinence at 5 months. The study includes 110 women with a high rate of instrumental delivery. The message is not that ultrasound should replace clinical examination. The message is that clinical examination may miss injuries and bedside imaging may become a diagnostic safety tool if feasibility and training are adequate. For patients, this can matter enormously. An unrecognized sphincter injury at delivery can lead to years of poorly explained symptoms: urgency, uncontrolled gas, staining, pain, social avoidance, and loss of body confidence. For maternity teams and rehabilitation professionals, the paper supports a more proactive model. Do not wait for a woman to return 6 months later saying that something is wrong. Document the injury better from the start. The final must-read in this first section is by Mamani et al. In International Urogynecology Journal, Effectiveness of Pelvic Floor Physiotherapy Techniques in Women with Sequels of Gynecologic Cancer, a systematic review. The review retains 10 articles on pelvic floor physiotherapy techniques for women with sequelae of gynecologic cancer. The most commonly described approach is pelvic floor muscle training, alone or combined with other modalities. Reported benefits concern sexual function, urinary incontinence, muscle strength, quality of life, and some pelvic pain or discomfort outcomes. The level of evidence is not perfect. populations are heterogeneous and cancer treatments vary, but the practical relevance is high, and this paper matters because gynecologic cancer sequelae are still under-referred to rehabilitation. After surgery, radiotherapy, brachytherapy, chemotherapy, or hormone therapy, women may experience pain, dyspareunia, dryness, fibrosis, urinary symptoms, anorectal symptoms, fatigue, and loss of confidence in the pelvis. Too often, these symptoms are considered the price of survival. This review reminds us that functional recovery is part of care. The goal is not to promise complete normalization. It is to offer structured, cautious, progressive rehabilitation, coordinated with oncology and gynecology, thematic dossier, pelvic pain, nerves, and diagnosis, beyond a purely local reflex. This week's dossier starts in primary care with an article in the British Journal of General Practice. Lowe and Peachy publish Women's Perspectives on Pelvic Pain, Insights into the Emotional and Diagnostic Journey in Primary Care. This questionnaire-based study was conducted in a United Kingdom general practice. Among 81 respondents, 45 women reported pelvic pain. Mean age was 41.9 years. Only 48.9% reported having a diagnosis explaining their symptoms. The words used to describe pain are strong, stabbing, agonizing, crippling. The mean impact score is 7.5 out of 10 for quality of life and 7.9 out of 10 for emotional well-being. Restrictions affect physical functioning, work, education, social life, relationships, fertility, and mental health. The most useful part is not only the intensity of pain, it is the diagnostic journey. Some patients report feeling validated and supported, while others describe dismissal, patronizing attitudes, confusion, and frustration. 7 women did not seek medical advice, citing normalization of pain or fear of not being taken seriously. This article does not prove that any treatment works. It shows a pathway problem. Pelvic pain is common, disabling, often multidimensional, and still too dependent on whether the first clinician knows how to listen, triage, and refer. For multidisciplinary practice, this is a blunt reminder: before technique comes recognition. A patient with years of pelvic pain does not only need someone to palpate a muscle or order imaging, she needs someone to rebuild a coherent clinical story. Menstrual cycle, sexual pain, bladder, bowel, lumbar pelvic symptoms, surgical history, obstetric history, infections, possible trauma, fatigue, sleep, anxiety, beliefs, and avoidance. This does not mean psychologizing pain. It means not searching too quickly for one single local cause. This idea is reinforced by a more mechanistic article in the Journal of Clinical Investigation. Harvey et al. Publish Repeatedly Occurring Retrograde Menstruation Intensifies Central Sensitization Driven by Neuroinflammation in Endometriosis Models. And this is animal research using rhesus macaques with spontaneous endometriosis and a mouse model of repeated lesion induction. The authors show that repeated retrograde menstruation and inflammatory stimuli increase lesions, hypersensitivity, persistent glial activation in brain or spinal regions, and nociceptive markers such as TRPV1, substance P, and CGRP in dorsal root ganglia. They also observed changes in peritoneal macrophage populations and persistent cytokine elevation. Dienogest and fingolimod reduce hyperalgesia and neuroinflammation in these models. The direct clinical evidence level is limited because this is not a patient trial, but the conceptual value is strong. Painful endometriosis is not simply a map of lesions, it is an interaction between peripheral inflammation, the peripheral nervous system, spinal cord, brain immunity, and pain memory. When a patient continues to hurt after surgery or hormone therapy, it does not automatically mean she is exaggerating, that there must be a visible residual lesion, or that rehabilitation should focus only on relaxing a muscle. It may reflect central sensitization and sustained neuroinflammatory processes. For clinicians, this paper supports a multimodal approach: gynecologic treatment when indicated, graded physical activity, pain education, sleep, stress regulation, body-based therapies, adapted pelvic floor rehabilitation, and coordination. We now move from endometriosis to pelvic neuropathic pain with Cayley et al. In European Spine Journal, Sciatica Beyond the Spine, a prospective study on laparoscopic neurolysis of pelvic, sciatic, and sacral nerves demonstrating long-term improvements in pain, function, mood, and bladder symptoms. The starting point is simple. Not all sciatica comes from the spine. Intrapelvic entrapment of sciatic and sacral nerves may cause chronic pelvic pain, sciatica, dysmenorrhea, dyspareunia, dyschezia, dysuria, vulvodynia, coccygodynia, and pudendal neuralgia. The authors follow 25 women, median age 36, with at least 2 years of refractory pelvic neuropathic pain. Diagnosis is based on neuropelviological examination and 3 Tesla MRI. All patients undergo laparoscopic decompression of the sciatic and sacral plexus. The results look striking: no conversion, no motor deficit, pain scores reduced by 70 to 90% at 1 month, sustained improvement at 6 and 12 months, and improvements in SF36, PHQ9, and OABV8. But caution is essential. This is a small, non-randomized, highly selected, and highly specialized surgical series. It does not mean that every neuropathic pelvic pain patient should undergo laparoscopic neurolysis. Its clinical value lies elsewhere. It forces us to think about the nervous pelvis, not only the spine or the pelvic floor. In a patient with pelvic pain, atypical sciatic radiation, urinary symptoms, dyschinesia, dyspareunia, and an unconvincing lumbar MRI, the conflict may be intrapelvic. For physiotherapists and physicians, this is not an invitation to overdiagnose nerve entrapment. It is an invitation to recognize the profiles that do not fit the usual framework and refer to teams able to reason in neuropelviology. In the same anatomical logic, Eschkintan-Reverdy et al. Publish in International Journal of Gynecology and Obstetrics applied surgical anatomical approach to pudendal nerve, step-by-step key neurovascular structures for pelvic nerve surgery. This descriptive anatomical study is based on 60 hemipelvises from 30 female cadavers. The authors propose a surgical approach in 3 stages and 9 steps to identify the pudendal nerve and its anatomical relationships, especially with the sacrospinous ligament and the ischial spine. They document branching variations and surgical landmarks intended to reduce nerve injury risk during complex pelvic surgery, deep infiltrating endometriosis surgery, or pudendal neuralgia surgery. And this is not a treatment efficacy study, but in a week focused on pelvic pain and nerves, it is relevant. Pudendal neuralgia is often discussed in consultations, sometimes diagnosed too quickly, sometimes missed for too long. The pudendal nerve is not an abstract label. It travels through a complex surgical, ligamentous, vascular, and muscular environment. For surgeons, the article provides a roadmap. For rehabilitation professionals, it reminds us that pudendal pain can be influenced by mechanical, scar-related, postural, and neural factors, but also that manual therapy has limits. For physicians, it reinforces the need to distinguish pudendal pain, vulvar pain, myofascial pain, radicular pain, and centrally sensitized pain. Another diagnosis that is often delayed is pelvic congestion syndrome. In Annals of Vascular Surgery, Garcia Valencia et al. Published Pelvic Congestion Syndrome Retrospective Analysis Single Institution Series reported in Latin America. The study is retrospective, but the cohort is large, 1,294 patients after excluding pure venous compression syndromes. Patients have pelvic symptoms and imaging findings compatible with pelvic congestion. They undergo phlebography and usually coil embolization of gonadal veins. In this series, 77.7% are multiparous, 56% report dyspareunia with a mean VAS of 6.6, and 50.8% report dysmenorrhea with a mean VAS of 6.9. Gonadal embolization is performed in 90.3%. Symptom improvement is reported in 86.8%. Among those with complete VAS data, dyspareunia decreases by 70.8% and dysmenorrhea by 72.4%. The overall complication rate is 1.7%, with 0.59% major complications. Again, caution: retrospective, single center, no control group, but the topic matters too much to ignore. In chronic pelvic pain, pelvic congestion is still sometimes neglected. We think about endometriosis, bladder pain syndrome, myofascial pain, irritable bowel syndrome, but less often about pelvic venous insufficiency. Signs are often nonspecific: heaviness, pain worsened by standing, dyspareunia, postcoital pain, dysmenorrhea, vulvar or lower limb varicosities. For first-line clinicians, the goal is not to diagnose and treat alone, but to know when to suspect it and where to refer. Dysmenorrhea is also part of this week's pain thread. In PLOS 1, Sen et al. Publish Association between Attendance at a Behavioral Change Communication Module and Dysmenorrhea Prevalence among Female University Students. The study examines female university students in Bangladesh and evaluates the association between attending 3 behavioral change communication sessions and dysmenorrhea prevalence. After propensity score matching, the authors obtained 98 pairs. Overall dysmenorrhea prevalence remains high at 69.4%, but is lower in exposed participants, 61.2% versus 76%. 27.6%. The average treatment effect among the treated corresponds to a 23 percentage point lower prevalence. Exposed participants also report more regular physical activity and greater dietary diversity. This is not a randomized trial, so causality cannot be assumed, but the signal is useful. Menstrual pain is not only a matter of analgesics or hormonal contraception. Information, physical activity, lifestyle behaviors, normalization of care seeking, and recognition of warning signs all matter. For a multidisciplinary audience, this paper has public health relevance. Action can begin early in schools, universities, primary care, and community clinics before pain becomes a 10-year story. On the vulva side, Wu et al. Publish in Lasers in Surgery and Medicine clinical outcomes of fractional carbon dioxide laser treatment in women with vulvar lichen, simplex chronicus, a retrospective study with 12-month follow-up. The study includes 88 women with vulvar lichen simplex chronicus treated with 3 sessions of fractional carbon dioxide laser. Clinical signs, vulvar pruritus, dyspareunia, and patient-reported global improvement are followed up to 12 months. Pruritus and dyspareunia VAS scores decrease significantly at 1, 6, and 12 months. Overall response rates are high. 89.8%, 93.2%, and 88.6% at the respective time points. Around 70 to 78% of patients report improvement or marked improvement on PGIC. This is a sensitive topic. Vulvovaginal lasers have been promoted in several indications with variable and sometimes insufficient evidence. Here, this is not a general recommendation, but a retrospective study in a specific vulvar skin condition. It should be read as a signal, not as a broad green light. For patients with chronic itching, dyspareunia, scratching lesions, and long diagnostic journeys, the main reminder is that vulvar pain is not always primary vulvodynia. We must examine the skin, treat dermatoses, work with dermatologists and gynecologists, and avoid reducing every vulvar pain presentation to pelvic floor overactivity. Briefs, anorectal surgery, bladder residuals, and neurological sexuality. First brief, in Techniques in Coloproctology, Vigiri et al. Published Bridging the Gap, a systematic literature review and meta-analysis on the management of rectal wall defect after transanal excision. The surgical question is whether the rectal wall defect should be closed or left open after full thickness transanal excision. 6 comparative studies are included. Closure is associated with less rectal bleeding, odds ratio 0.57, and fewer readmissions, odds ratio 0.34, at the cost of slightly longer operative time. Other outcomes are not clearly different. For non-surgical clinicians, the lesson is that anorectal functional outcomes also depend on very concrete technical choices made in the operating room, not only on secondary rehabilitation. Second brief, Du et al. Publish in Journal of Investigative Surgery, Vascular and Wound Healing Implications of Single-Stage versus Multi-Stage Repair of Anorectal Malformations, a systematic review and meta-analysis. The paper compares single-stage and multi-stage repairs of anorectal malformations in neonates and infants. 19 studies and 1,972 patients are included. Single-stage repair is associated with a higher risk of wound dehiscence, odds ratio 3.31, without significant differences in infection, stenosis, prolapse, redo surgery, constipation, soiling, or voluntary bowel movements. This is not primarily a rehabilitation paper, but it reminds us that anorectal trajectories may begin very early, with long-term implications for wound healing, vascularization, and function. Third brief, in International Urogynecology Journal, Ruiz-pérez et al. Published Clinical Relevance and Symptom Burden Associated with Elevated Post-Void Residual Urine in Women, a cohort study. The cohort includes 239 women with post-void residual urine above 100 milliliters, median 290 milliliters. Associated symptoms are mainly recurrent urinary tract infections, mixed urinary incontinence, overactive bladder, and stress incontinence. A clinically striking point is that 88% of patients require intermittent self-catheterization, with a major reduction in symptom burden. Mean VAS decreases from 7.2 to 1.7. For practice, the reminder is simple. Measuring a residual is not a technical detail. In some women, it explains recurrent infections, urgency, leakage, or persistent bladder discomfort. Fourth brief, Bladder, Sexuality, and Neurology intersect in the study by Mazzoni Costa et al. In Spinal Cord. Partnered sexual activity and satisfaction in women with spinal cord disease, influence of urinary incontinence, and other predictors. The study includes 98 women with traumatic or non-traumatic spinal cord disease followed in neurourology. Urinary incontinence is present in 52% and severe in 28.6%. Partnered sexual activity is reported by 49%. Among sexually active women, 58.3% have FSFI, defined dysfunction. Incontinence is strongly associated with sexual inactivity and lower FSFI scores. Urinary continence predicts sexual activity and satisfaction, with an odds ratio of 5.0. The message is direct. In women with neurological disease, sexuality is not secondary, and incontinence is not only about pads or infections. It affects intimacy, willingness to engage in relationships, body confidence, and satisfaction. For rehabilitation, neurourology, and primary care teams, this supports asking explicitly about sexuality rather than waiting for the patient to raise the issue alone. Final brief. Aho Felt and Myra Lid publish in Techniques in Coloproctology, Advancement Flaps in Perianal Fistulizing Crohn's Disease, Technical Steps and Current Evidence. This narrative review discusses advancement flaps in perianal fistulizing Crohn's disease. 11 studies and 305 patients are identified with highly variable clinical healing rates ranging from 23 to 91%. This variability reflects patient complexity, luminal inflammation, cetons, biologic therapy, and stomas. The clinical message is that sphincter-preserving surgery is possible but cannot be considered in isolation. In chronic perineal suppuration and pain, control of inflammation, drainage, and coordination between gastroenterology, surgery, and rehabilitation remains central. Conclusion. This week, the literature pushes us to widen the frame. Pelvic pain is not only organ pain, it may involve inflammation, nerves, vascular factors, scars, skin, sexuality, bladder, rectum, obstetric history, the central nervous system, and the diagnostic journey itself. Low and Peachy in the British Journal of General Practice remind us that many patients first need to be believed, oriented, and understood. Harvey et al. In the Journal of Clinical Investigation remind us that painful endometriosis may be embedded in central sensitization and neuroinflammation. Kayla et al. In European Spine Journal remind us that some sciatic pain may be intrapelvic. And the anatomical work by Eshkintan-Reverdi et al. Reminds us that pelvic nerves are not abstract. They sit at the center of surgery, pain, and the limits of our treatments. Alongside this pain dossier, the must-read papers show that sexual and pelvic functions are gaining stronger evidence. Exercise and female sexual function, pelvic floor muscle training and premature ejaculation, NeuroSAFE and post-prostatectomy recovery, pelvic floor muscle training during pregnancy and postpartum, transperineal ultrasound in the delivery room, and physiotherapy after gynecologic cancer. The common thread is clear. Pelvic function is not limited to continence or no continence. It involves sexuality, autonomy, confidence, pain, movement, sleep, social life, and quality of life. Thank you for listening to this week's watch. Always check the full study details and official guidelines before changing clinical practice. And references are available in the description, and I'll see you next week for a new episode.